everyone, my name's Aisha. I'm a dual qualified foundation doctor and I'm the programme lead for the OMFS Survival Guide. This talk is on clerking a patient, which whilst it may seem like a little bit of a dry topic, I do find is something that's really important that you have an idea of before you go into your jobs, because as you know, we're all taught at dental school, documentation really is so important. So the aims of this talk are to give you a structure for clerking patients in different settings, such as A&E or in theatre. Hopefully you'll be able to understand some important points when you're clerking patients with different pathologies, and to also gain an overview of how to write ward round notes. People seem to be a little bit confused and unsure, especially when you first start, of how you to structure ward round notes, so we'll go over that as well. So what is clerking? It's basically a fancy way of saying, what you know of documenting your patient visits as a dentist. So it's a record of the patient's presentation. So you're going to be documenting, the presenting complaint, the history of the presenting complaint, patient's medical history, drug history and allergies, their past surgical history, any family history and a social history as well. You will write your examination findings and a diagnosis or an impression if you're not sure what's happening, and an initial management plan in those notes as well. It does vary depending on where the patient is because, say for example for a post-op patient admitted from theatre, you won't have quite as much in the history bit, whereas you would have more in the history if you're seeing a patient on A&E. So I thought that this was useful not only for clerking but just in general to understand different patient pathways and different ways that patients can be admitted onto a ward and where they come from. So do note this may be a little bit different depending on where you are. Your hospital protocols and your COVID protocols may mean that some of these pathways aren't quite the same as what I've got here. But so the first way and the most common way that you'll be admitting your patients whilst you're on call is through A&E. So in lots of places, the patient goes from A&E to what we call a holding ward. So this is the surgical admissions box that I've put here. In some areas, it's called the surgical admissions lounge or the surgical admissions unit. In more recent years, actually, this has become the place that patients stay whilst they're awaiting the result of their COVID swab. So it's a bit of a strange place because they're in a hospital bed, but they're not actually in their final hospital bed. So once they get their COVID swab back, they then move to a surgical ward. So say when the patient is admitted to the surgical admissions lounge, this is where you would write you would see your patient on A&E, you would write your notes on A&E when you see the patient. And then when the patient gets admitted to the surgical admissions bit, they then need another admission clerking for when they reach the ward. For those of you, hopefully that will be working in hospitals with online documentation, there'll be different types of documents that you can open, and we'll go over the differences in what you would write in those different documents. So the next pathway here I've got is patients who come into theatre for a planned procedure, an elective procedure such as a BIMAX. So for those patients, you'll see them pre-op and you're going to clerk them. So you're going to write something in the notes, and then after they've had their procedure, they will be admitted to a ward. So then you go and you write another admission clerking. These patients usually have had some sort of pre-op COVID test, so they have been booked onto a bed for a final surgical bed. They don't need to go via the SAU. Patients can be admitted to clinic. Sometimes, we see patients and they're a bit more unwell than what we thought, or we think, oh, actually they need, a bit more of an urgent procedure. So again, you would write your notes on clinic, and then this patient will need admission documentation. So this is where it gets a bit confusing because it depends on your local policy, because some of these patients may be able to go straight to a ward. I think this is unlikely now with COVID. I think the vast majority of patients will have to go to this SAU or the COVID amber ward and have to wait for a final bed again. Lastly, sometimes we do arrange for patients who are at home for whatever reason to be admitted directly. So sometimes we're arranging for a semi-elective procedure, or sometimes there's a fractured mandible and the injury's been missed by A&E and we've picked it up somehow. So these patients, again, it can be possible for them to come straight onto SAU if you discuss it with the bed managers, but usually we have to ask the patient to come to A&E, which is very inconvenient, and it's often quite frustrating for the patients to have to wait in A&E to then go to the surgical admissions lounge, to then go to another ward, but unfortunately this is just how things are. So you can see the different points at which you're going to have to document for the patients that are highlighted by the little star icons in the box, and they're all a little bit different, which we will go over. So this, going over clerking the major cancer operation, if you don't work in a unit where you do these operations, just skip ahead a couple of minutes because it won't be relevant to you. But for those of you that do, the reason that I've put this one first is because this clerking is so important, and it's usually the one that's actually done most inadequately. Patients who are coming in for their head and neck cancer resection, they may be having reconstruction with a free flap, and they're often very complex patients, like both medically and surgically, and they are going for a very complex surgery. So it's really, really important that everything is done properly and everything has been checked, because they will be coming in the day before for, to make sure that they've had all of their tests done and to make sure that everything is in order. The first thing that you need to write when you're clerking the major is their diagnosis and the treatment plan. So you can usually find this on a clinic letter. For example, it may be something like a T1, N1, M0 of the right mandible admitted for a hemimandibulectomy, reconstruction with a left fibula, free flap and tracheostomy. If the patient is having a free flap, so this is where we transfer a part of tissue, say like a radial forearm free flap, it will come from your forearm, and if I was having half of my tongue removed, this bit of tissue would be used to plug the hole from where we've removed the area of the tongue. You absolutely must know which side that flap is coming from and where it's coming from, because it's so important that no blood or no cannula is put into any of the vessels on that side, because if it ruins the veins that they would use to plumb the flap in, we then can't use that side for the free flap, and if we can't use the other side, then we're a bit stuck. So you need to go get a skin marker, and you need to write no needles in really big letters all over that patient's, whichever, their right arm, left arm, leg, or whatever it is. You should be checking for any new symptoms, because this patient does have cancer, and any certain symptoms may affect the treatment plan or whether or not they're even fit for a general anaesthetic. Even though their medical history will be all over their clinic letters, do take another one and make sure that nothing has changed since they were last seen. You do need to prescribe all of their regular medications, so if you're unsure about, if they can have certain things before their operation, do speak to your reg or the anaesthetist, because some of them are held the night before. So, for example, we don't give ramipril on the morning of an operation because it makes it very difficult to control the patient's blood pressure, and they can also get a kidney injury as well. Some patients may also need some new medications pre-op. One of the major ones is to prevent blood clots, such as a low molecular weight heparin. We do have a talk on VT prophylaxis, so I won't go into that now. The patient's social history is really important, because patients may sometimes need the alcohol withdrawal pathway. Usually patients who are alcohol dependent are brought in a few days beforehand for detox, but sometimes it just depends on how much they've been drinking. They may also need nicotine replacement therapy as well. Any imaging needs to be checked. So all of our patients should have an OPG, because we always assess their dentition, and if they need any extractions, then we will be doing those in theatre when they have their cancer resected. With regards to bloods, they should have had recent bloods done, and if these are more than a couple of weeks old, they should be taken again in case of any issues. This G and C that you can see in that bracket stands for group and cross match. So that's a blood test that's taken to match the patient's blood type for a transfusion, which most patients will need, like either during the operation or after the operation, because it's a really big, long procedure. It is only valid for a few days, so if the patient has a sample more than 3 days old, you need to call the lab and ask how many more they want you to take. In terms of other investigations, all patients will need an ECG, that can just be done at the bedside, and I would take it to a medical doctor just for them to have a look if your registrar isn't around. And I'd also have a look to check the clinic letters to see that they don't need something called an echo. This is an ultrasound of the heart that assess their cardiac function prior to having a GA, and sometimes the anaesthetist will request them, but depending on where the patient has come from, sometimes the request gets a bit lost or they get sent elsewhere and we don't have access to it. So we need to make sure that the anaesthetist is able to access that. And some patients may also have been sent for pulmonary function tests as well to assess their lung function if they've got COPD, to see if they're fit for a GA. I would always check the patient's observations. Yes, at this point they are being admitted electively, but we must also always be making sure that our patients are well, and that there's nothing obviously kind of causing a problem pre-op. Consent form, so it's not appropriate for you guys at this stage to be consenting for this sort of procedure, but you do need to be making sure that there is a signed consent form and the checklist sort that whatever your hospital is using is done. And if it's not there, just let your reg know, who will be in theatre, or the consultant, whoever is around. And you need to also mark the patient if it's unilateral. So say if they are having a right hemiglossectomy, then you want to draw an arrow on their right cheek. Check the patient's concern. So these patients are undergoing huge life-changing surgeries. If they have a tracheostomy, they might not be able to speak to you for some time post-operatively. So it is really important to have a chat to them, address their concerns, and if they will have questions that you probably can't answer, but let your reg know, because we want to make sure that all of our patients do receive holistic care. We're not just there to put them to sleep and do an operation. We do want to make sure that everything is in order for them, both physically and mentally, and that we're supporting them in any way that we can. So once our major patient has had their operation, they usually go to ICU or like a high dependency unit, because they often have a new tracheostomy, or they've had a very big operation, and they may need support with things like their blood pressure and airway monitoring and things. And those places have more nurses basically to care for the patients, and they have ICU doctors who are very well versed in looking after critically unwell surgical patients. So once they've been on ICU for a few days and the doctors over there are happy that everything is okay, they will then return to the ward. And sometimes the documentation and prescriptions are a little bit all over the place, because ICU and HDU often use like either a different documentation system, or they have different protocols and paperwork, and everything's just can look quite confusing, especially at first when you're not used to it. A lot of hospitals will have what we call a step-down protocol. So that is basically a checklist thing of what you need to check. But just in case you work somewhere you don't have a step-down protocol, here's a summary of what you should be looking for. So when the patient comes back to the wards, you want to go and see them as soon as you can, just to make sure that everything is okay. So we want to ask the patient for any issues that they might be having. So we want to make sure that their pain control is adequate, make sure that they're not kind of, they haven't been struggling with anything specific. You must always look at their observations. I've put some exclamation marks there because that may direct you towards that there is a problem, and ideally we would like to identify problems before they occur, and often you can kind of see trends in observations where things are developing. So have a look and make sure that they are normal. If there's anything you're not sure about or anything you're worried about, speak to your registrar. Have a little look at the patient's recent bloods. Again, these will often look quite deranged. We do have some talks on how to interpret blood tests, and your own units will be going through that with you. And again, you learn most of it via experience, but you do want to be looking at them to see if there's anything obviously wrong on there. A lot of these patients will have tracheostomies. So there is a bit about tracheostomies in the A to E assessment talk. But basically, you want to make sure when the patient comes back to the ward that there is an inner tube. So there is one main tube that goes into the patient's trachea, and then there is usually a smaller tube inside that. The inner tube is basically there for you to take out if there's a problem, because sometimes that gets blocked up with gunk. So you can clean that. You then don't have to remove the whole tracheostomy, like the main tube is still in there. You just take the smaller one in. And you also want to have a look at whether or not the cuff is up or down. So what the cuff is, it's a balloon around the tube inside the trachea. So when it's inflated, it blocks off most of the saliva from your upper airway dripping down the trachea. And usually patients aren't sent to the ward until that cuff is down, because then we know that these patients are managing their secretions, their airway is safer, but you should know these things. Make sure the ICU meds have stopped. So they prescribe some very strong painkillers and blood pressure support medications and sedatives and things. Usually they should stop all of these, but sometimes I've certainly had it where patients have come back to the ward and they've been still prescribed like propofol or something. They shouldn't be on that on the ward. So, if you're unsure, again, ask your registrar. But generally speaking, as time goes on, you will know what those medications are and make sure that they're not on there. And also check the patient's own medications are prescribed appropriately, because sometimes the patient's had certain things stopped pre-op that should have been started after their operation, but it hasn't been. And there's other things that may need changing in terms of the route or the kind of formulation. So, for example, if a patient's got a tracheostomy and they were previously on inhalers for asthma, those inhalers need to be changed to a nebulizer because it's quite difficult to use an inhaler with a tracheostomy. And, if a patient has an NG tube, you can't put tablets down an NG. Everything would need to be liquid. Some meds can be crushed, but again, check with your nursing team and pharmacy. VT prophylaxis, like I said, we have a whole talk on this, but patients should at the very least have the TED stockings on, and usually a low molecular weight heparin prescribed. There are some contraindications to these, so again, it all depends on the patient, but it is something very important to be aware of. You also want to be checking their drains, so patients often have drains coming out of their neck, and you want to know how much is in them and how much has sort of been coming out of them over the last 24 hours. There should be a chart for people to be writing these things down on. And in the same vein, another tube to be looking at is a catheter. We want to know whether or not the patient is catheterized. You want to have a little look at the colour of the urine that's coming into the bag. If it's really dark, it's an indication the patient may be a bit dehydrated and may need some extra fluid. Okay, so that's enough about our major patients, and now on to something that will hopefully be relevant to all of you. So this is documenting the notes for patients that come in through A&E. So they are very similar to what you'll be used to be writing for your dental notes, but with a few additions. So the plan is really important here because the nursing team will follow the instructions on here. So if a patient's for theatre and they need to be nil by mouth, you must write that on there, in a very clear area, because they will usually just be looking for that. They won't read the rest of your notes. Going kind of through the other sort of sequence of what you should be writing. So that BIBA stands for brought in by ambulance. You can write that if they have been brought in by ambulance or referred by their GP or GDP or self-attended to A&E. And then, as you would expect and as what you're used to, you want to write about the patient's presenting complaint and a bit about their history of presenting complaint. If they are a trauma patient, we want to be asking about any other sort of symptoms, pain elsewhere, just to indicate any other possible injuries or any other sort of symptoms. And for that, we should be doing a systems review. Always really important to document a full past medical history and drug history. These patients are going to be admitted to hospital. We'll be giving them medications, so we need to know if anything's going to interact or if we need to stop anything in the meantime. We also want a bit of a history about any previous surgeries that they've had, any family history of any conditions. You're then going to examine the patient and document your examination findings. Investigations wise, so some of these patients, usually A&E, because they see them, they will have ordered their bloods and taken them, or they will have already taken an OPG before they've even called you. So you can write a little bit about what the investigation findings are. So for example, OPG shows PAP lower right 7, or FBC shows raised white cells in line with the submandibular abscess, something like that. You then want to write what your diagnosis is or your impression if you're not entirely sure, or you can write a couple of different differential diagnoses, and then the plan. The other thing is that the patient is also going to need their own medications prescribing. So sometimes, especially if they've just come into A&E, they don't have them with them, they don't know what they are. I hope everyone should have access to the GP summary care record through your own hospital computer system. So this is where you can look at the patient's GP record. You can see what their past medical history is and what their drug history is. It's really important to know that you have access to that because it's an invaluable source of information. The other thing is that the pharmacists go through and check all the prescriptions and make sure that everything is up to date. All of the regular medications have been prescribed. So if you get any phone calls from pharmacy saying, oh, this has been missed off, or you've put this on and actually they're not on it anymore, it's because they will also check the GP record, and usually they have a very up-to-date summary as well. So we'll say that you've done your A&E notes, your patient is now on that surgical admissions lounge, and you now need to fill out your admission clerking. It doesn't need to be exactly the same as your A&E documentation because it functions more as a summary that we can look back to for when the patient came in. So it still needs certain details, but you will be able to see that there are a few differences here. So, rather than writing out your entire history, you'll create a summary of the important factors. So, for example, patient has fractured left angle of mandible, or patient has right-sided submandibular abscess from lower right 6. The past medical history and drug history and allergies, surgical, family, social history, etc. should be in there as before. Your examination, you want to write your findings and some important negatives. So, for example, a patient with a fractured mandible, might have some numbness in the distribution of the left mental nerve, deranged occlusion. You don't need to write all of the negatives. As time goes on, you will know what is important to write, but it's just important to remember that this is a medico-legal document. So if something happens or the patient puts in a complaint, they will be combing through these notes and they'll be reading what you wrote. In terms of the investigations, again, that is kind of the same as what you would write on A&E, what has been done, what's awaited. Writing what has been done already as well is really useful for your colleagues coming onto a shift. So say, for example, if you've kind of only really managed to do a bit of someone's admission, you can write somewhere like treatment given, IV antibiotics, IV fluids, needs further analgesia, and then your colleague knows, I need to prescribe them some more pain relief. The plan is, as before, for example, keep nil by mouth, consented book for theatre, etc. So last one now, ward round notes. Again, another area people do skimp on because ward rounds are often quite rapid, but like I said before, these notes are a legal record of your patient encounter, so you must write down as much as you can. I always tend to start with a bit of a general statement of the end of the bed assessment. So, I'll write something like the patient is alert, sat up in bed, or patient sat out in chair, or patient looks well, patient looks unwell, looks in pain, etc. If the patient has any complaints, you would write those down, or you write nil complaints or no new concerns. On examinations, so your examination findings. Often your reg is going to be examining the patient and they don't always tell you everything. So I would ask them exactly what you want them to write, because it may be something like, neck is soft, nil erythema to incision, or swelling improving or something. But, especially if they have, say, examined a patient's abdomen around like a peg tube, there may be something that they have identified that they haven't necessarily said out loud. So just make sure you ask them exactly what is to be written in the examination bit. And then you would kind of just write the general conversation that occurs as best you can. You don't need to write it word for word, but you can say like, advised patient, operation has gone to plan, needs suture removal on this day, or discussed numbness to left lip, may or may not resolve, etc., blah, blah, blah. And then again, another plan. So it could be like, keep nil by mouth for theatre later, continue IV antibiotics, or order chest x-ray, or discharge today. Like I said, that is the bit that the nurses read. So anything, especially that is very pertinent to them. So keeping nil by mouth is really important so they don't feed the patient by accident. Or, start NG feed. All of these things do need to be documented. So again, ask your registrar or the consultant, whoever is doing the ward round, what the specific plan is for that patient. So thanks for listening to this talk, guys. A little bit of a dry topic, but something that is very important. As before, any questions, please do send us an email or check out our website. We're always happy for feedback as well, so please do fill out the feedback form if there's anything that you think that we could improve upon for next year as well.